morning and welcome. My name is Nita Sardana, and I'm the VP of Community Outreach and Corporate Giving at Innova Solutions. I also have the honor of leading and directing the Innova Foundation with more than 200 partnerships in the US and around the globe. Throughout November, which is Diabetes Awareness Month, the Innova Foundation, in partnership with the Emory Global Diabetes Research Center, or the EGDRC, will host insightful conversations with subject matter experts on this ever increasing global issue. We will gain insight into the strides being made in medical research and discuss preventive measures that individuals at risk for diabetes can utilize to either mitigate or manage the disease. Today, I have the pleasure of speaking with Dr. K.M. Venkat Narayan, EGDRC Executive Director, Global Diabetes Prevention and Policy. Welcome and thank you for joining us today.
Thank you, Nita. It's a pleasure being here. Look forward to this conversation.
Absolutely. Venkat, can you explain your role for the listening audience?
Yeah, I direct the Emory Global Diabetes Research Center, which is a cross campus university level center at Emory. We have over 160 odd faculty from various disciplines, all focused on diabetes. And we also have a lot of partnerships in up to 25 countries. In India alone, we have 12 different institutional partners. The focus of our center is really to unearth the causes of diabetes, particularly with a lens on the global pandemic of diabetes, and to see this and to find solutions, both lifestyle solutions, pharmacological solutions, and technological solutions.
That is really great. I mean, you're really covering every single part of the solution that you could possibly and every way that you could. What do the global diabetes numbers look like today?
Yeah, the most recent data, which is published in the Lancet, was that there's over 800 million people with diabetes globally. And in 1990, this was less than 200 million. So a huge increase already and continues to grow. And what's also shocking is half the people with diabetes globally are not diagnosed. I mean, this could be much higher in some countries. And besides, when you look at the leading countries in terms of numbers of people with diabetes, the most of the burden is in what we call low and middle income countries. For example, India has nearly over 200 million people with diabetes, China more than 140 million people with diabetes, and then of course the United States, it's number 3. So here is a disease which is affecting every country, every region in the globe, rural, urban, semi-rural, everything. And it's going up, and it's mainly affecting low and middle income countries where the disease is occurring at younger ages and even at lower body weights.
Wow. Wow. Those numbers are just terrifying actually. And to think about it that not even, everybody knows that they're diabetic or not. That's even more scary. There have been lots of debates about how many types of diabetes there are. So what are the different types of diabetes?
Yeah, currently the classification of diabetes, the WHO classification of diabetes, there are currently 3 accepted types. What we call type 1 diabetes, which affects about 5 to 10% of all cases worldwide. And there, the primary problem is the pancreas does not secrete insulin because of autoimmune suppression of insulin secretion. So it's an autoimmune disease. And like I said, it affects 5 to 10% of the population of people with diabetes. The second type is, before I come to type 2, is what we call gestational diabetes. This is diabetes that occurs in the mother during pregnancy, and after pregnancy it goes away, but still increases the risk of diabetes in the mother in the future and increases the risk of diabetes in the offspring in the future. So these are the 2 accepted types. The third is the type 2 diabetes, which really has largely been thought of as a garden variety. It's probably multiple different types of diabetes, and we are increasingly finding, for example, that type 2, there are 4, 5, 6 different varieties of it. And, that is where, for example, traditionally, type 2 was believed to be largely related to obesity and related to be due to insulin resistance, where the body is producing insulin, but insulin is not acting well. But our studies in global settings and also in high-income countries is beginning to reveal that there is a large number of people who have type 2 diabetes. They don't have the autoantibodies, they have type 2 diabetes, but this is because of poor insulin secretion. So therefore, we can think of type 2 diabetes as multiple diseases, and this is where the classifications are going to likely increase. There's at least one variety that is dominantly driven by poor insulin secretion, another variety that is driven dominantly by high insulin resistance, and there might be mixtures, there might be diabetes related to aging, etc. So this is an area that our center is actively involved with in terms of researching.
So you would say that type 2 diabetes is probably the most common?
Yeah, type 2 diabetes affects 90 to 95% of all diabetes worldwide. And in fact, in most of low and middle income countries, 95% of diabetes is type 2. And this is where we think further reclassification is required, because what we have understood to be type 2 diabetes is probably multiple diseases, and some of which have been understudied. And those understudied variants, like the insulin secretion deficiency variety, seem to be extremely common in many low-income countries of the world.
We never think about diabetes as maybe multiple diseases. So we're really looking forward to what the research is going to come up and tell us, and how we can reclassify some of those people that are diabetic but really may have something else. So what are some common misconceptions about diabetes?
Yeah, the first misconception is that we know everything about diabetes. It's completely wrong. I mean, like I said, like you correctly said, 80 odd percent of diabetes worldwide is in low and middle income countries, but just about less than 2% of the diabetes research happens in those populations. So the most of the populations commonly studied have been European populations, and we are now learning that generalizing those findings to the whole world is not working. So that's number one. The second misconception is there's something like, you can have mild diabetes. I have people say I have borderline diabetes. That's not true. The person either has diabetes or does not have diabetes. And the reason that distinction is important is because having diabetes increases the risk of all kinds of diseases. I mean, like it can affect the eye, leading to blindness, kidney disease leading to renal failure, kidney failure, limb disease leading to amputation, heart attacks, stroke, liver disease. So it's a very prolific disease. Secondly, the third very important thing is that people say, oh, I've got diabetes, it's genetic, there's nothing I can do about it. True, a lot of type 2 diabetes is genetically driven, there's no question about it, but it's also lifestyle driven. So it's a combination of genes and lifestyle. And based on the prevention studies that we have done so far, there is strong evidence that even if somebody has the dominant genes for diabetes or multiple genes for diabetes, with active lifestyle, a lot can be done to try and prevent or slow the progression to the disease. I mean, like Jocelyn said something very famous long time ago, the genes may load the cannon, but it's always the environment that pulls the trigger. So I think a lot can be done. And finally, people think there's not enough treatment for diabetes. In fact, there is a lot of good treatments available. In fact, those treatments are expanding. And as a result of applying those treatments in a systematic way with great access and affordability, we are finding that in many high-income countries of the world, diabetes-related complication rates and diabetes-related mortality or death rates are going down. But this has not benefited the low and middle-income countries of the world. And that is where we need to work, trying to increase access and making therapy and technology affordable to 800 million people with diabetes worldwide.
So basically, if a person knows that they're pre-diabetic, there is a way to reverse that. If good diet, exercise, healthy program, they probably could even reverse getting the diabetes.
Definitely, there's data showing, our large trial showed that if somebody with pre-diabetes embarked on, say, 30 to 45 minutes of physical activity daily, and also followed a healthy diet, such as a diet low in refined carbohydrate, reasonably high in fiber, a decent amount of proteins, high in fruits and vegetables, with that, and then kept their, lost, if they're overweight, lost 5 to 7% of their body weight, then you can prevent diabetes by about 50%, or at the very minimum slow or delay it. There are also recent studies showing that you might be able to send diabetes into remission. We don't say you're cured, but you can go into remission. So there are studies showing that. There is a lot of But the problem is implementing that in practice is where the challenge is.
Excellent, excellent. So there's hope out there.
Absolutely.
So, what role do you see for emerging technologies such as telehealth, wearable sensors, AI, precision medicine in diabetes prevention and management?
In lots of different ways, lots of different ways. I mean, technology is going to play a remarkably important role in the delivery of both prevention and management for diseases like diabetes and also for other diseases. I mean, firstly, like you said, telemedicine. Telemedicine allows us to reach, I mean, particularly in places where specialists are not well distributed or places without specialists, there's no reason why telemedicine can't be capitalized to provide access to specialists and to integrate primary care with specialist care. So that number one. Secondly, mobile health. The use of smartphones can be of huge value both for the patient. I mean, patients can, it can be used for nudges being sent to the patients to manage the medication, reminders for them to come back, and also educational programs, like, for example, the lifestyle intervention program, which is usually about 24 sessions, has been converted into mobile programs, can be available in an app, and can be very valuable. So mobile health is going to play a big role. But then increasingly, we are also finding wearable technology. You can use a wearable technology to measure your glucose in a continuous fashion, measure your blood pressure in a continuous fashion, and then measure your activity levels, measure your dietary intake, measure your stress levels. That's going to be huge. And finally, the role of artificial intelligence. I think increasingly there is great promise. We think artificial intelligence can help us better predict who's going to develop diabetes and its complications, better predict what kind of treatments or prevention will work for whom. Like, again, we spoke about different types of diabetes. We need to clarify in terms of which type of diabetes will respond to what kind of treatments. Again, AI has a big role there. And then, also to prognosticate, to give people ideas of who are you likely to develop a heart attack? Are you likely to develop eye disease? So AI can play a big role there. And also a big role for AI for healthcare delivery. If you can combine mobile health and AI and the wearable technology, there's no reason why we can't shift more and more of the care directly into the hands of people and into the hands of the community, where the specialist medical care becomes a support structure for referral cases. And so there's a huge model available for revolutionizing how we deliver care. So I think technology is going to play a big role. But regardless of whether it's technology or therapeutics, like I said, there are 12, 13 different classes of drugs. The big challenge is going to be not the innovation of technology or innovation of the next generation of great drugs, but making them affordable to the people across the world. I mean, even now, let's take the GLP-1, for example. Those drugs are very powerful, but only a minority of people with diabetes, even in the United States, can even afford it. Whereas low and middle income countries are not affordable. And we did a model exercise checking if the GLP-1 drugs were made available to everybody in the world who requires it. People with obesity, people with diabetes with indications for it. You can save 35 to 37 million deaths in a 5-year period, and you can reduce obesity levels globally by half. But how do we deliver this? It's so expensive. How do we bring down the costs? How do we increase its delivery? How do we increase people's compliance? How do we prevent its misuse? I think those are the challenges that we are grappling with.
Wow, wow. Just imagine, I mean, if we could get all these things under control, we'd probably see a lot different numbers and people in much better health, not just in diabetes, but overall. So yeah, I'm really, looking forward to what AI and all the technology is going to be able to do for the medical field. Yeah, thank you. You've done a lot of work in India and other low and middle income countries. What differences in diabetes presentation or risk have surprised you?
Yeah, I worked with the NIH for 4 years and then for CDC for 10 years before I moved to Emory University in 2006. And the intent was really to start doing work globally. So my initial feeling in the year 2007 was all that we had learned in the US and in Europe from our research was going to apply directly to countries like India And all that we needed to do was go and implement programs in India. But in the very first year, I very quickly learned that that was not going to be true, largely because we were seeing in countries like India and in China and other parts of the world people who are obviously not obese, people with BMIs of 17, 18, 19, but with type 2 diabetes. So, I mean, so the question is, we spoke about weight loss, for example. You can't go and tell us a person with a BMI of 19 or 20 to go lose weight. It doesn't make sense. And secondly, so the question is, are these people really insulin resistant as what was thought of in the United States? Because we had a lot of obesity, which induces insulin resistance. So we started looking more and more into whether these people in countries like India were not secreting enough insulin, and lo and behold, that's the direction it has taken us. So, number one, you're seeing higher frequency of diabetes that may not be related to obesity, but may be related to poor insulin secretion in countries like India and other countries of the world. And secondly, the complication rates may be different depending on the different types of diabetes. And more importantly, in countries like India, because of poor diagnosis, poor treatment. That's not just India. Many of the low and middle income countries, poor systems to deliver care. People, suffer from a lot of complications, and a lot of unnecessary years of life and years of suffering happens because of that.
Wow. Wow. That the low income countries may not have as much obesity and the things that you're talking about with the insulin. It's really something to think about. Thank you for sharing that. What is needed to advance research and innovation in this field?
I mean, firstly, when you look at the data, I said there's over 800 million people with diabetes globally. Over 80% of that is in low and middle income countries, but about 2 to 3% of global research is in those populations. And let's, focus in on India, for example. Overall, in terms of global burden, India contributes to something like close to 25% of the global burden of diabetes. But research in Indian populations globally, including in India and in the diaspora together, accounts for about 1% of the global research. So this gap between where the burden is and where the research is happening is stark. And I think, number one, we have to change that. And that is where the Emory Global Diabetes Research Center has been playing a big role in making that argument and also actually doing that work by building partnerships with across the world and by doing research that is relevant to those contexts, number one. And secondly, it is very important to train the next generation of researchers in this field who are globally minded and who can also. So, for example, we have various programs where we've had over 300 people, young investigators from India, come and spend time at Emory, and from other countries come and spend time with Emory and go back to their countries. We've also had about 40 US investigators go and spend up to a year in India and in other countries. So this global workforce is extremely important. So I think more research is definitely needed. But in addition to more research, there's a lot that can be done now. For example, taking the great proven interventions, whether it's for prevention or for care, and systematically applying it. And this is where management sciences become extremely important. A lot of diabetes is not just the doctors or the great specialists. It is organization of care at the level of the system. For example, how do you organize care? How do you organize team care for people with diabetes? How do you organize diabetes around centers? How do you have a system of data? You spoke about technology. Data plays a huge role. So can we have a system of electronic medical records which are easy to implement, through which can be used to know which are the patients requiring extra help and can be prompted, which are the patients requiring different types of treatment. So I think all of this are required. More research, more training of investigators, greater collaboration globally, and very importantly, the idea of let's implement the highest quality of care everywhere through system-wide changes to the organization and delivery. And finally, let's, when we innovate new technologies and new medications, let's also keep in mind that we need to lower the cost in a way that they can be affordable to large numbers of people.
Absolutely, absolutely. I mean, that is the whole key, right?
Yeah.
To reach that larger patients and people with diabetes is to really lower that cost. So in 5 to 10 years, how do you hope the global diabetes landscape will look different?
I think, I'm optimistic. I feel that there is a lot that can be done. I think clearly there's been a great growth in terms of technologies, in terms of our ability to molecular, techniques, our ability to measure lifestyles objectively, etc. So those things are going to grow. And like I said, the other second thing that's going to happen is we're going to get more and more precise about the types of diabetes, particularly the types of type 2 diabetes, and align treatments more appropriately to the right types and to the right. So it's not a question of treating any diabetes as a one size fits all. It's asking what diabetes you have and treating it appropriately. So that is definitely going to happen. And then I also believe that many low and middle income countries are actually experiencing considerable economic growth. I mean, like, for example, you look at economic growth across the world, it's much more faster across
Mhm.
many large low and middle income countries and even small low and middle income countries. This provides an opportunity for them to invest in research and in building their health systems, for chronic diseases. I think influencing that process is also very important. And finally, I think the realization that diseases like diabetes or COVID don't respect borders for a number of reasons,
Yeah.
I think brings into the perspective the need for greater global collaboration to solve this. And I think it needs to be a two-way street. There are lots of lessons you can learn in country like from China, Brazil, India that are applicable here in the US or in Europe because they are dealing with large scale. They have to bring down the cost of medications. They have to bring down, like we learned in the vaccine area. Yes, in the US and Europe, we came up with mRNA vaccines, but countries like India produced 60-70% of the global vaccine to bring COVID under control and made it affordable. So I think we need to think in those terms. I mean, a great book by a management expert called C.K. Prahalad, who wrote about the bottom billion of the pyramid. So rather than seeing the poor people of the world as victims, see them as customers and try to come up with your products that'll be affordable to them. For example, maybe the GLP ones, like the low cost vaccines, should have versions that are available to people in low and middle income countries. Maybe the AI models have to be built in countries like India and made available across low and middle income countries. So I think more global collaboration. I see value in each of these areas.
Excellent, excellent. So, what role do you believe that centers like Emory Global Diabetes Research Center should play in shaping that future?
I think pretty much along the lines of what we have been doing. So, on the one hand, we have embarked on research in an all encompassing way. We're looking at basic sciences in terms of the cause of disease. We're doing epidemiological studies where cohorts, we have a cohort called PCARS, which is following up 22,000 people in India. That CARS is about 4.5 times the size of the Framingham Heart Study, which is a very famous cohort. We've been doing trials of prevention. We've been doing trials of various treatment. We've also been doing quality improvement trials, working with the Indian healthcare systems and in Mexico, in other countries of the world. And finally, we are using technology and also speaking up for greater investment and doing a lot of advocacy and policy changes. So I think this is the role. But the challenge for us is keeping this running because at the end of the day, doing research, we've been reliant on certain models of funding. And I think it now behoves us to think broader. So we need to influence, the low and middle income countries to invest more in research for their own country so that they can partner with people like us. And similarly, we are looking to philanthropy and to individuals to help support funding so that funding doesn't become the issue not to do what is the right thing to do.
Absolutely. And if anybody who's listening over there is interested in helping to fund the diabetes research, you can reach out to Emory Global Diabetes Research Center, or you can even reach out to here at the Innova Foundation or Innova Solutions, and we'd be happy to guide you in whatever donations you would like to make. This is great. Well, thank you so much, Venkat. Innova Foundation is very proud to partner with Emory on this effort. From where I sit, the cost of failing to manage this crisis is more than dollars and cents. It's lives, it's careers, and communities that cannot achieve their full potential. Our investments today will yield generational benefits. Innova Foundation is proud to be at the forefront of what has the potential to be world changing breakthroughs in diabetes prevention and treatment. To everyone in this audience listening, thank you and have a wonderful day.
Thank you, Nita, and having friends and supporters like you makes all the difference. Thank you very much.
Thank you, Venkat, for joining. It is really a pleasure to speak with you every time. Thank you.
Thank you. Bye bye. Bye bye.